Tammy says pumpkin spice. Thank you for turning that on, Crystal. I appreciate it. Oh, there's Laurel. Oh my goodness, we have a good crowd today. I love this. I think it's just going to continue to get bigger. Anybody else have any fun smells that remind you of autumn or this time of year or even early winter? Chainsaw exhaust. Okay, I can dig that. It's a whole thing. I understand. It's a whole thing. Baked goods and soup, definitely, definitely. Mita, what is that?
It's the name for when things have been dry for a while and then it rains, like the first rain smell.
Oh,
It's like
yeah,
the little actinomycetes or whatever getting kicked up off the ground.
for sure, for sure.
I
Hi,
love that
Kathleen.
smell, Maida, but how do you say that word? Is it pedicore?
Petrichor.
Petrichor. I missed the R.
Yeah,
Kathleen, I'm sorry, go ahead.
I was just gonna nerd out about it. It's actually it's Greek for the like the nectar that flows in the veins of the gods or something like that.
Ooh, I make a fragrance oil that I call one of them's Mother Earth that has a little bit of floral in it, and the other one's called Cemetery Stroll because it smells just like that. You either love it or you hate it. I love it.
Well, that works for October.
Totally.
Oh yeah, Jerry, I bet you are tired of that, especially where you're at right now. That is, I remember when I moved back to Washington, the summers would hit in Wenatchee, and by like mid-July, early August, it was that heavy, hot smoke all the time. So I could completely understand why you'd be tired of smelling that for sure. All right, well, it's 9:05 and we're going to go ahead and get started. I'm sure folks will continue to trickle in. For those of you who don't know who I am or don't recall, my name is Amanda Major Polly. I'm the Peer Support Program Administrator for the Division of Behavioral Health and Recovery. And this is the Peer Blend. It happens the first Thursday of every month from 9 to 10. If you're here and you have your own registration link, it is good for the entire series. So if it doesn't come up at the same time next month, you could still just copy paste that registration link, create a tickler in your Outlook, and you should be good to go. Also, something that we started back up again, thank goodness, is the ability to record these. So they'll be recorded and then links will be put up. Hopefully, we can start creating a catalog again and putting the previous month's Peer Blend link into the peer-to-peer newsletter. So if you are interested in a topic, but you can't attend because of a different obligation, you'll have the ability, if you want to go backward and take a look at it again from there. So today, though, we have the amazing Maida Hogan, and she is on to talk about some fantastic or her fantastic program, the Peer Pathfinders, and all the wonderful things that peers are doing in our outreach community. So, Maida, I'm going to pass the baton on to you. And and a quick question before we do that. Do you want questions at the end or would you like questions intermixed?
Intermixed is fine, but then depending on how the slideshow shows up on my screens, I might not be able to see the chat. So if
Okay.
people drop questions in the chat, I can either get them afterwards or people can shout them out to me or whatever. But I definitely don't mind being interrupted.
Okay. Well, I'll let you know if there's something in the chat and we'll go from there.
Right on.
All right.
So I'll
Take it
just
away.
a little bit about myself. Maida Hogan. I use she, her pronouns. I oversee the Peer Pathfinder program and also the host Homeless Outreach Stabilization Transition Program at HCA. And I've been doing that for about 4 years now, almost 4 years. Before that, I worked in direct service for a long time, doing outreach work and supervising outreach workers, particularly people with lived experience doing outreach. So this program is really like I was working at Capital Recovery Center in Olympia when this program started back in 2017, the Peer Pathfinder program, and I got to sort of watch it roll out on the ground and help implement that. So it's kind of my baby. I'm really excited about the possibilities that it brings and the amazing work that our teams do. So I'm stoked to be here presenting, and I'm going to test my technical skills now with sharing. Do, do, do. Okay. Can y'all see my screen?
Sure can.
Cool. Wow, I can't reach my buttons though. Okay, fine, go away. Sweet. Okay, from the beginning. So the Peer Pathfinder program, talked a little bit about myself. So what it is. So the PATH program, Projects for Assistance in Transition from Homelessness, started back in like the 90s. And that's okay. Thanks. To do outreach to folks who were homeless, who were experiencing serious mental illness. And as that program sort of got implemented and was evaluated, one of the things that they found was that there was this population that was not served by that needed those kind of exact services. So while PATH is focusing on folks with serious mental illness, they were encountering a lot of people in their homeless outreach who were experiencing substance use challenges and not SMI. But that needed that outreach and rapport building and connection to services. So basically, what they did was they took the PATH program and like just copy pasted it and changed serious mental illness to substance use disorder. So the basic idea is that it's funded by the state opioid response grant. And the basic idea is that we would attach 2 people with lived experience to each PATH outreach team and have them do outreach to folks with substance use disorder. Initially, also, there was this idea that we were going to do outreach through emergency rooms. I'll get a little bit into that. So that was a bit of a divergence from the PATH model. Okay, so the intent is to reach those most at risk of overdose. This again started back in 2017, so it's kind of an acknowledgement of that sort of peaking opioid crisis at the time, and the acknowledgement that there were a lot of folks who were experiencing homelessness or unstably housed who were really particularly at risk of overdose, and were not necessarily accessing treatment and recovery services. We currently have 11 Peer Pathfinder teams throughout the state. We are going to it is October. Starting in October, we're only going to have 10. So that's kind of a big change. It's been 11 since the beginning. Eligibility criteria. So anyone who's 18 or over can enroll in the program. But because it's an outreach program, the teams end up interacting with folks who may or may not, they're not carding people while they're on outreach. So they might interact with folks who are under 18 and meet the other eligibility criteria. And they just wouldn't enroll those people. They would do rapport building. They would help them connect to services, but the program isn't really designed to serve folks under 18. So it's not really, an appropriate age group for this program. Individuals with opioid use disorder. So we started with specifically just opioid use disorder. And then couple of years ago, I want to say 2 years ago, we expanded that to folks with stimulant use disorder. It's sort of acknowledgement that with the drug supply being as sort of unpredictable as it was, and with fentanyl showing up in stimulants and other drugs, that people would be at risk of opioid overdose, even if they weren't specifically seeking or addicted to opioids. So one of the things that we did this year that was kind of cool, about a year ago when we started our grant year last year, We actually expanded it to anyone using any substances who might be at risk of overdose or drug poisoning. And again, that's just an acknowledgement that the circumstances that people are living in are really kind of unpredictable. The drug supply is really unpredictable, and people might be exposed to things that they don't even know are out there. So anyone with a substance use disorder or who's using substances who might be at risk of overdose is eligible for the program. The priority population is really folks who are experiencing homelessness or who are at risk of homelessness. And then also anyone who's experiencing a substance use health crisis. So like I said, the program was initially designed to also go into emergency rooms and connect with those folks who might be, might have experienced an overdose or some other kind of substance use related medical crisis, like an abscess or myocarditis or things like that. So that, as folks are accessing emergency services for that, they might be cycling back out again and not getting connected with treatment recovery services. So Peer Pathfinder sort of uniquely designed to catch those people as well to sort of stop that revolving door. Okay. So we do engagement. It's an outreach program. We go out into the world and engage with folks, get to know them, build rapport, build trust. We have to go to all kinds of places just to catch people wherever they're at. So the teams go into homeless encampments, streets, alleyways, wooded areas, overpasses, all the kinds of places you can imagine people might be living that are not intended for human habitation. And then also hospitals, emergency departments, and mental health agencies. We have some of the teams that do outreach into correctional facilities and inpatient facilities as well, although that's less common. And then public spaces, so in reach at places like libraries, churches, soup kitchens, other service providers. And then the program is also equipped to take referrals from the community. So that could come from crisis responders, law enforcement. Sometimes, folks, just community members will call and say, hey, I, came across somebody that I think might need your services. And so the teams can respond to those referrals as well. So the teams provide, once the engagement has happened and the rapport is built, we're providing services and we're also providing referrals. So under the services umbrella, a lot of the services that get provided by Peer Pathfinder teams fall under the heading of case management services. So it's, when you enroll somebody in Peer Pathfinder, you're going to sit down and work with them to sort of come up with a service plan. Whatever their goals are, whether it's to access housing or, to build their income or to go to treatment, to write those goals down and then come up with steps toward them and work with that person to develop that plan and then to work the plan. So a lot of case management stuff, and then connecting people to services. So assisting them with making appointments, helping them get to appointments, helping them connect with services that support them with their daily living activities, making sure that they have access to transportation, if people want to go to school or do vocational training. Yeah. And then the biggest one is probably the housing services. So in most communities, there's like a coordinated entry or some other kind of like central housing services. And the Peer Pathfinder teams work really closely with those housing services to make sure that folks get access to housing that is available. And then as peers, they're also providing one-on-one peer support using their lived experience. So the way that we describe it when we onboard folks into the Peer Pathfinder program is there's kind of two hats. And in a given day, they might be, putting on their business hat and doing case management and helping get people to appointments. And then a lot of times in the middle of that, they might have to pop that hat off and put on the peer hat and be with somebody and use that lived experience to connect with that person and help them, develop hope and imagine and design their own recovery and access their self-efficacy. And then referrals, again, any kinds of services that people want that help them stabilize and get healthy. So primary care services, withdrawal management, detox, inpatient, outpatient treatment, medications for opioid use disorder is a big one. Housing services, income assistance. A lot of the Peer Pathfinders are familiar with the the SOAR process, the SSI, SSDI Outreach Access and Recovery, which is a sort of an expedited disability application through Social Security. So they can help folks with those applications, which is a huge barrier for folks who are disabled and can't work. And having that help is a big deal for them. Okay, data collection and reporting. One of the things that really frustrated me when I was working in direct services is that it seems like I was actually really mad at HCA for a long time because, it's like fill out this spreadsheet and enter your data into HMIS and do this and do that. Put in a referral, put in whether the referral was attained, put in that you met with this person. Every single time you meet with them, you have to put that in. And then it seemed like nobody was actually looking at that data and nobody, it didn't really come back around in a way that was useful. So it wasn't really designed for, someone who's overseeing an outreach program to be able to improve their program based on that. So that was one of the things, that's kind of one of my bones that I pick. So with the Peer Pathfinder program, we actually switched from HMIS to the REDCap program, which is a data collection program that's sort of initially it was designed for medical research data collection. So it's secure and it's also really customizable. So we were able to sit down with our providers and say, hey, what kinds of things would you like to know about your program? What kinds of questions do you want answered about the work that you're doing? And how can we build that into this tool so that when you're collecting the data, then it comes back around in a report that says you're serving these people demographically, you're providing these services, and we can kind of look at that. So I'll give you, here's an example. So this is the grant year for Peer Pathfinder goes September to, it's actually September 30th to September 29th. It's really awkward. So this is a little more than 3/4 of the year is what this covers. So September 30th to July. And the things that we look at, so this is for the whole state. And I get this report, and then I also get an identical report for each site that shows exactly the same information. And so that's one of the things that I'll sit down with providers and go through it and just sort of look at, how the program is working. We have an annual target for enrollments, 495 statewide. It's pretty unambitious. And we always meet it. So I try to give them stretch goals, other things that are a little bit more challenging. But you can see as of July, we'd already enrolled 627 folks. So we kind of blew that target out of the water already. So yeah, we look at new enrollments. So you can see usually there's a spike in the winter. But this is so for each month, these are the new folks statewide that were enrolled in the program. And then we can look at the demographic data and make sure, usually it's going to be less than half of them are female. That's just a kind of general fact in homelessness or in unsheltered homelessness, at least. So that's not really surprising. And then age group, usually that ends up being about an equal distribution across sort of middle-aged folks. And then race and ethnicity will vary based on the community that they're in and the types of services that are available in that community. So yeah, we'll just look at that and say, does that look reasonable? Does that feel like are we hitting folks? Does that line up with your demographics for your community? Is there any reason why that might be different? Is there anyone who's not getting served? And then along the bottom is sort of the service stats. So outreach location would be the place that they first got encountered. It's going to be primarily street outreach. And then you can see, treatment facilities, emergency departments, and correctional facilities. And then substance use, we have it broken out so that folks either get categorized as using opioids or using stimulants or using opioids and stimulants or using other substances that are not opioids or stimulants. So this helps us track based on treatment type. So if folks are accessing medication for opioid use disorder, we want to be able to know how many of those people. We don't want to be dividing by the total number of people that are served because then it looks like people aren't accessing treatment. But if somebody is primarily using methamphetamine, for example, they're not going to be interested in medication for opioid use disorder. So we broke it out this way so that we could track that a little bit better. And, when we look at our outcomes, we can actually get a really clear sense of how many people are accessing treatment and what types of treatment. Living situation at intake is pretty straightforward. Most people are going to be homeless. A lot of times you'll see, so with particular providers in particular communities, sometimes they'll have like a really good relationship with an inpatient facility, and they'll be helping folks transition out of that. So a lot of their living situation at intake would be, in a facility or incarcerated. But across the state, this is pretty average. And then types of engagement and types of referrals, again, pretty straightforward. Obviously, we're going to have to change harm reduction to some other code word because we're not saying that anymore. But yeah, harm reduction, peer SUD support, and peer mental health support are the big ones. And then referrals to obviously housing is number one. And then folks getting, referred to treatment. So I can't see the chat, and I also can't see the clock. So I hope I'm on track here. I feel like I'm rambling. Okay, so starting last October. Okay, cool. We switched from HMIS to REDCap for data collection. We expanded the eligibility to include those without opioid or stimulant use disorder who may be at risk of overdose. And we provided a little bump in that we were able to identify some additional funding. One of the challenges from the beginning has been that the amount of funding hasn't changed significantly, but the expectation is still that each team will have 2 FTE. So that's been a challenge for a lot of the teams in terms of, if you can't pay people competitively, then you have a lot of turnover or you have a lot of burnout. And so, recognizing that when we did get additional funding, we said, hey, we know you need to pay your people more. Here's some more funding to do that with. And in the future, we're going to improve services by tracking qualitative data. So one of the things going into this year is we're going to look at doing like quality improvement plans for each team to have them identify ways that they want to improve or expand on their existing services, and then track that throughout the year. We would love to add partial FTE for supervision and data quality, but I don't think that's that's not in the cards with the current budget. And would love to expand to more rural and tribal adjacent areas around the state. There are entire swaths of the state that are just not even covered by these services.
Hey, Maida.
Yeah.
There's a couple of comments and questions in the chat.
Cool.
One of them, Kathleen wants to know is, do you track disability status? Is the first question.
Here, let me, that was the end. So
Oh, okay.
See if I can figure out how to unshare. Did I unshare? Or am I still
No, we can still see your screen.
Okay, thanks.
Are you looking to stop sharing?
Yeah, I can't find it in the menu though.
I think if you go to the top of the screen that you're sharing,
Oh, there
there
it
should
is.
be
Stop
it's
share.
it's not as it's a different kind of intuition than Teams, right?
Yeah, the thing is, I used to be like Zoom for everything, and Teams was weird, and now it's the other way around.
Yeah.
It was a great looking screen, though. I'll give you that. I enjoyed looking at it.
Yeah, that little frog on the last one, that's actually a frog from my pond, and it's like in the process of
Aw.
its tadpole tail, and I'm like, oh, it's like a little sign of future hope.
I love that. So Kathleen Murphy wants to know, do you track disability status?
I am no, and I don't know how I would define that. Like if somebody like self-attested disability status or disability benefit qualification, or I feel like there's a lot of different ways to do that. I'm curious. Yeah, is it what would that help? Because I'm also
Kathleen,
taking notes to improve the
Kathleen, do
program.
you feel like coming off of mute and kind of going into it a little bit deeper?
Oh, sure. So individuals with disabilities oftentimes experience inequities and challenges with connecting to social supports. And so having that as a data point can oftentimes be really helpful in determining how we might engage folks, or are there any disparities in who is, out there and needing additional support.
Yeah. And how would you define, like, if you're sitting down with somebody, I'm sorry, I'm like going to put you on the spot because I'm actually really curious about this. If you sit down with somebody and you're like kind of doing the get to know you, maybe take down some of their demographic information, what would you just have them self-identify as having a disability, or would you want there to be a particular definition?
So for me, as someone with a disability, I always like to be asked what, if I have any access needs. Is there something that I need in order to fully participate? It's not necessarily a question about disability status, but if there's some barrier, it's
Mhm.
imperative that there is some kind of a disability there.
I love that access needs. That's like so specific, and it's something that people can really like grab onto and then not have to go into detail if they don't want to talk about their particular disability. That's awesome. Um, okay.
So there's a lot of questions and comments around the use of overdose prevention versus harm reduction. And
Mhm.
Naomi asked if we aren't using the phrase harm reduction anymore because of the current executive order.
Yes. Uh, yeah, I think we're using overdose prevention as sort of the an equivalent term that's not quite as uh, offensive to the people who don't like harm reduction.
Thank you.
Yeah.
Odessa wants to know if there are any barriers or disabilities you might be willing to share. I think as far as tracking disabilities or determination of services and things like that, is there anything that says yes, as what I'm taking from this? And Odessa, pop off of mute and correct me if I'm wrong. I'm just interpreting, the best that I can. Um,
I think it was more along the lines of when she was asking her about how she would, have that conversation. I know that when we do our intakes,
Oh, yeah.
that's something that I don't ever like to just, because it does say disabilities or barriers, but I always like switch the wording around to try to meet the client where they're at. Like, are there any barriers that you're experiencing at this time or any disabilities that you'd like to share? Rather than just like, do you have disabilities? It's just a way that I word it, that I try to get the client to open up and using words, like we, or just because it's not always just the person on the other side. Like, we always experience things, as humans. So that's how I usually get them to open up about any barriers they might be facing. And then we kind of go down a list of things that if they're willing to share or identify.
Yeah, that's awesome. I think it's something that comes up in those conversations. It's not something that we track, but it's definitely, when you're doing the service planning for folks, the barriers are going to be one of the first things that come up. So people saying like, yeah, I haven't been able to get a job because, whether it's discrimination or lack of access or those barriers get addressed in the service planning process, but it's not something that we ask specifically, but I'm taking notes about how to talk about this as potentially like a technical assistance conversation for teams going forward if they have questions about how to address this question with folks. So I appreciate this.
Yeah. And I usually also just tell them that like vulnerability will be your best friend in these moments. And it might be hard at times to share, but like, please be as vulnerable as you can possibly be with no judgments on my side, and just try to let them know like, I'm human, right? And I'm just trying to put the barrier down for them to be able to access any need they need.
Yeah.
so Maida, I have a question. As far as like I worked in Path for a couple of years in the past, a very long time ago. And I knew what resources we would offer 352 years ago. What is the guidance that you give to the individuals working the Path and Peer Pathfinder program about what they can, what is a good, basically, what are the resources that are typically offered for folks who are experiencing instability in housing or SUD struggles?
Yeah, so a lot of that is going to depend on the individual community and what resources are available. So sometimes, like withdrawal management might not be available, within 150 miles. So that's something that if somebody's specifically wanting that, then the issue would be trying to figure out how to get them there, right? Whereas if somebody's looking for housing, there might be, there might be a central place you can go, or you might have to put in applications at multiple places. So it really varies in terms of what the sort of service matrix in the community looks like. But I think there's another question there too. I think that's what things can't we do as peer pathfinders? So that's a big one. I mean, people the people who do this work have really personal reasons for doing it and are really passionate about it and really, really want their people to succeed. And sometimes that looks like uh, maybe like being a little bit unprofessional in a really beautiful way with people. So it's like it's a little bit on me and the program supervisors at the provider level to make sure that folks are doing that in a sustainable way and not putting themselves in situations where they might be endangering themselves or the people that they're serving. I definitely had a really interesting, like I had one of the peer pathfinders, this was a couple of years ago, bragging about how well she was taking care of one of her participants. And she said, yeah, I even do childcare for her when she goes to her treatment appointments. And I was like, I don't think that's not part of your job.
Mike, the deep
Can't do
sigh.
that for everyone. Yeah. Yeah. But I mean, it's the kind of thing that, if you don't already know that you're not supposed to be doing that and you have an impulse to help people, then yeah, so that's something that happens pretty frequently where it's like maybe you want to be able to connect people to services and then there's not available or they're not eligible or whatever, and then you're trying to fill that gap, and sometimes people want to go in and fill it with their own body and be like, it's okay, I got it. Yeah.
Yes, yes. It's a learning curve too. Like it really is trial and error figuring out what's acceptable and what's not. Like if you're gonna go out into the community and do outreach down by the river, maybe not heels and slacks and
Yeah.
blazer. I might have learned that lesson the hard way. And knowing who to talk to in the community, and the things like that. So that's very yes. Ethics and boundaries, especially boundaries are something I feel like especially peers learn a little bit more and more and more with every encounter. And you don't know what you don't know, right? And we get mixed up between that empathy piece and that need to help people succeed.
Mhm.
Rosalind, I have seen you come off or come on cam like 3 times. Do you want to speak up? Do you have something to say?
No, just apologies for coming in so late. And I am sitting in my doctor's office, full disclosure, so I may have to sign out in a minute, but I want to make sure that I came in and listened to what's happening.
We appreciate you, Rosalind. Thank you. I just wanted you to know that I saw you.
Yeah, sorry for being late.
No worries. No sorries. We're just glad you're here and getting this great information. I will make sure to send out the slides to everybody who registered for this, if Maid is willing to share them, of course, which I hope
I'm
so.
sending you now.
Thank you. So if you're interested, and then, but this is a great time for this open conversation. We still have a little bit of time left, folks. So if you have questions or you want to know how you can become involved in some way, even as a community partner, now is definitely the time to start asking those questions.
Oh yeah, I can definitely connect folks with the Peer Pathfinder teams in their communities if that's something that feels helpful. I'm going to put my email in the chat.
I have an issue just so, and it's personal. But I have someone who's now home with their children part-time, have undocumented mental health issues and possible issues so that they have them. I don't know where they are in that journey at this point. But they are homeless as of yesterday. Um, I've been out of the ring for a little bit, to circle a little bit. So I don't know where to, I told you with MD, um, but I'm not sure where to make referrals to them,
Yeah.
for them for. I
Where are
don't.
you located at? I didn't
I'm
I
sorry.
didn't catch. Where are you located at?
They're in Tacoma, Washington.
Oh, okay. Yeah, there's a Peer Pathfinder team at Comprehensive Life Resources.
Okay.
I will do you have access to the chat?
I do.
Okay, I'm gonna look up the contact for that team and drop it in the chat for you.
Is it possible that I can send you put my email in the chat and then send information there? Because like I said, I'm not in a position of gathering.
Oh, yeah.
Thank you.
I know there's some pause thinkers in here.
So, how do you become a peer pathfinder?
Well, you would just apply at whichever agency is the provider for Peer Pathfinder in your community.
Okay.
There's
Okay.
2 positions per team, and I'm hoping for less turnover, but there's some turnover, so I guess it's always a possibility. Most of the places that have Peer Pathfinder teams also have related, like the Path team, or they'll have like the peer services, some other way that that you might be able to get your foot in the door. Yeah.
All right. Thank you.
Yeah.
I just want to say that I think it's really exciting that you don't have to put things in HMIS anymore.
Yes. That's like if I didn't do anything else, that would be good enough. I would be so
Right?
proud of myself for that, because it's
HMIS
like,
was quite a learning curve, wasn't it?
yep. Yep.
Robert
And
had asked if people volunteer to work with teams to help gain experience.
Potentially that would depend on the policies of the particular provider in terms of being able to accommodate volunteers. I'm sure some of them would be able to, but some of them might have policies around that, especially on outreach. There might be liability issues.
Sure. So, Maida, what are the requirements, the basic requirements or the standard requirements to be a person working as a Pathfinder?
So again, individual providers might have additional requirements, but the only requirement for, coming down from the Peer Pathfinder program is that folks have lived experience. And a lot of the providers expect that folks will be certified or be able to get certified.
Okay.
Yeah.
All right. And you said you're moving from 11 teams to 10 starting this month?
Yeah, one of the things with the funding challenge, the fact that the funding has stayed the same and the cost of living has gone up, we lost King County this year, and it's not a surprise. It's been a few years that we've been trying to figure out a workaround for them, and making exceptions and trying to keep them on board, because that was such a good Peer Pathfinder team. I love them so much. But eventually the county said we can't pencil it anymore, so yeah.
Misty wants to know, what website do I go to so I can renew my peer license in February? Misty, I'll put the link in the chat. That's a me question for sure. In fact, I happen to have it up right here because we are just that cool. It stays right here on our in our browsers all day, every day. So will it shift at all, Maida, where folks might have to move their credentials to from CPC to CPSS in the future in order to continue?
So that's the certification isn't a requirement of the program. So again, that would be down to each individual employer what their requirements are for that.
And what are and like so and I'm sure that this has evolved 1,000 times, but now I'm curious, speaking of requirements, once a participant is, if they aren't currently enrolled in Medicaid and they become enrolled in Medicaid, is it then that they get passed off to another team? Is Pathfinder short term, like 90 days, or what does that look like?
Yeah, so the idea is that it's supposed to be sort of a transition to connect folks to ongoing services. One of the things that we find, particularly in communities where there's not a lot of housing, is that folks kind of stay unstable for a longer time. So they might be accessing treatment and recovery services, but they're still kind of struggling with their recovery because of their living situation. And so they might not be able to follow through with participating in some of those more mainstream treatment services. They might just need additional support to overcome those barriers that come with being homeless. So it's not a strict time limit. We do require that that the service plan gets updated every 90 days. So at that point, you would then reevaluate, like, does this person still need this level of support, or are they ready to transition to, something a little more permanent?
That's awesome. Um, and Odessa wants to know if there are any teams in Snohomish County.
There's a team in Bellingham, so that's my North Sound team. There is a host team. So my other program, yeah, that is for. I know it's the service regions are like, there's like, yeah, we have a team in Spokane, but if you live in Okanagan, there's a host team in Everett, and so host eligibility is a little bit of a higher bar in that folks have to be really impaired by the acuity of their substance use symptoms. So they have to be like really unable to access services. But that is a possibility if there's, somebody in the Everett area or in Snohomish County that needs those kind of services.
And can you remind us, just so that we have a little touch more knowledge, what exactly is host?
It's the Homeless Outreach Stabilization Transition Program. It was part of the Blake bill, so it's been around for about 4 years. So that was actually what I was brought on to do, was to oversee the statewide expansion of it. It is based on a model that started at Downtown Emergency Services Center in Seattle. And again, it's kind of similar to the Peer Pathfinder program in that the DESC host program was really intended to serve folks with serious mental illness. And then when the Blake bill happened and we needed to identify how do we make sure that people are getting the treatment services they need, they looked at that host program at DESC and said that would actually be a great model for addressing this need for folks with SUD. So it's a multidisciplinary outreach-based service provision team. It's kind of like a really low barrier PACT team. In that each team will have some combination of credentials that allows the team to prescribe medications, to provide nursing services, and referrals to specialists, peer services, mental health and SUD assessment services. So but yeah, the idea is that they're not doing it. They're not bringing people into their office. They're actually going out and like sitting in a camp and doing wound care or doing the assessments. Yeah, it's pretty cool, actually.
That's why I'm smiling. I'm like, I kind of love that. Makes me happy.
Yeah.
So I know some programs happen to have occasionally, subsidies attached to the program. So for host and for Pathfinder, it is entirely referral out and support for referrals, or what does that look like?
We had for maybe 2 years, we had subsidies that were attached to some of the Peer Pathfinder and host teams, but that funding is no longer available. So, and that was just generally like, okay, here's subsidies that need to go to folks with SUD. And so we just decided to funnel it through those programs that were serving those people. It wasn't actually funding for the programs themselves. It was just kind of tacked on.
Okay. Like a backpack.
Yeah.
Okay. Does anybody else have any questions or comments for Maida? Did I miss anything in the chat by chance?
I kind of have a comment, a question slash just I want to share because when you guys talk about stuff that relates to anyone with mental health and substance use disorder and just the lack of services that there are out there for anyone that won't openly say that there is an issue, right? Like the law enforcement or the DCRs or anybody in our area specifically. Um, it's so hard to access some services. Like they have to have people that are willing to say they, use terminologies that they would harm themselves or harm someone else before they will actually help. So it's just really hard to see somebody in crisis. Law enforcement comes, we try to share and like, hey, this person is in a crisis. They need a crisis responder. They're harming their animal, and they're literally, you can tell they're in a either a psychotic episode or like I don't know, some sort of mental health barrier that is making them different than they were last week, right? And then uh, they leave. They're like, oh, they haven't committed any crimes. We're not going to intervene. And so I'm like, okay. And then the next day they end up with 3 felonies and 2 misdemeanors, and they're in jail, and their dog is in their house for a week. And it's just like nobody's helping this dog. We have no animal control anymore. The person was not of sound mind to say anything. I don't know. It's just a really hard area when we're dealing with mental health and like, especially in this county. So I kind of wish we had more in Snohomish County.
Yeah. One of the cool things that we're able to do with the Peer Pathfinder and the host program is and for eligibility, we don't require documentation or even self-report. If one of the outreach workers suspects that somebody might have a substance use disorder or a related challenge, they can enroll them and serve them regardless of that person's willingness or ability to talk about that or insight about it.
Awesome.
But that doesn't help with crisis because they're not crisis programs. There's 9 to 5.
Yeah. I mean, even if it wasn't, I was just speaking because this literally happened to me on the 24th to 25th, and I've been dealing with this dog alone, abandoned. So that was heavy on my heart. But like, yeah, definitely, even when it comes to anybody with substance use disorder that, getting county referrals from like coordinated entry and the HMIS and all of the things where I get my clients from. And it's apparent that this person can't even engage long enough to do an intake or anything due to fentanyl use, and the fentanyl use causing them to not want services because I don't know, or not want, I don't want to use that word.
People are legitimately, like with fentanyl, people are legitimately terrified of withdrawal. And I think that's something that we don't talk about often enough, is that when people are refusing treatment services, a lot of times it's because they're just terrified. With good reason. It's a terrifying process withdrawing from fentanyl. And, I think I get so irritated when people talk about people being treatment resistant or like not being interested in services. And it's like, no, you can't, like, medical science has not caught up with street drugs. We don't have a really
Narcan
good
somebody and they'll have mild side effects.
Sorry, say that again.
Or when they do Narcan training, it's like, oh, the person will be fine. It might have some mild side effects.
Yeah. And that's why they're recommending to do the lowest
through
dose. Yeah. That's why they're recommending using the lowest dose of Narcan possible to get the person breathing again, because you don't want to take them to that bad place. Yeah. Oh, thanks, Crystal. Yeah, the fact sheet for the Peer Pathfinder project is there's a link in the chat.
Has there been any improvement on detox beds?
Not really out here.
No, I would say overall, no. And it varies a lot by region. So overall, it's gotten worse. People are having more trouble accessing those services. And there are some communities where it's just, they have given up because it's just not accessible.
And they drop the amount of meds they'll give them during their stay there as well.
Mm.
Yeah, they definitely have done that out here. Also changed the dynamic of like what does detox look like. It's the benzos and it's the Suboxone day two. And like some people are like they've been on Suboxone so long their teeth are like sponge, you know, and it's painful for them every time they take their dose of Suboxone. So like that's another element altogether with the teeth issue from Suboxone use. And the drug use, obviously. But that's another thing in the treatment of care, you know, the compassion and all of the above. When I take, you know, my family to Tacoma and try to get them, you know, into a facility, I do the intake with her on the floor in a blanket, shivering, 82 pounds, and she has a little conjunctivitis left over with a prescription where she has already been to the ER and been treating. And then I drop her off and I'm like, here, I'm going to pick her prescription up right up the road and I'll bring it down. By the time I come back, they've got her outside because her eye
Wow.
infection is too bad. And I'm just like, she is at death's door. She's at death's door. Like it's my
Yeah.
cousin. Like I raised her. Like, and so
Yeah.
just the treatment of people has changed. And
And a lot of, I would say, yeah, a lot of facilities aren't equipped or trained to address people with, you know, really complex medical issues or those kind of intersecting comorbidities that require multiple credentials. You know, I've got somebody down in Vancouver who's been trying to get into treatment for years, but because she's a double amputee and has
Sure.
been like kind of, you know, traumatized by the treatment system, she's had a lot of difficulty and is now cannot find appropriate treatment anywhere. So, yeah.
No, I was really frustrated with where I work when they arbitrarily make the decision to, oh, we're going to cut this person's Suboxone down
Yeah.
because it'll help them get housing.
Yeah. Yeah.
I
I
mean,
think, you know,
isn't that illegal?
it, I don't know if it's illegal. It might be illegal for housing providers to require people to be at a certain dose of Suboxone. But I don't think I'm no lawyer. I'll say that.
Well, okay, I guess it's counterindicated to sustainability of sobriety.
It's definitely not what I would do. Yeah.
that would
Well, because it's like when someone's at a stable dose, that doesn't mean you just take them down. It means they're at a stable dose.
Yeah, and a lot of times the impulse to reduce the dose comes from a place of stigma and judgment. Yeah. And that's unfortunate because even just suggesting that the dose should be reduced when there's no medical reason to do that can make people feel like, you know, can set them back in terms of their sense of being in charge of their recovery.
Oh, most definitely.
Yeah.
So, Amanda, is there anything that we can do as a community to help support this program or be supportive through advocacy or anything like that?
Yeah, clap back on any bullshit you hear. If something seems like it shouldn't be legal, definitely question that. Um, you know, just punch up.
Punch up.
We need as many advocates as we can get in all communities. Yeah.
On that note, the people I work with, when they get discharged, they go places and they're having a hard time finding advocates to go with them to like appointments and stuff to help aid in that process.
Yeah. So there's a number of different programs that can do some of that, you know, and eligibility obviously overlaps or there's gaps in that. Peer Pathfinder is just one. The PATH program can help accompany people if they're eligible for that program. Recovery navigators have been really good with that in a lot of communities. Yeah, there are some that are, you know, funded locally that aren't HCA programs. Definitely worth looking into, you know, if somebody is needing that kind of support, maybe connecting with the outreach team in your community to figure out who they would recommend if they can't do it themselves. Yeah.
Well, you know, it's very overwhelming, and I mean, you said it, the stigma.
Yeah. Yeah, and it's unfortunate that we have to invest so much energy in helping people overcome barriers rather than reducing the barriers. You know, it's unfortunate that we continue to turn out medical providers who sort of have that like embedded stigma that makes it hard for people to access services. You know, it's unfortunate that the organizations that provide those services are set up in ways that are not trauma informed, and that are not comfortable for people to access. You know, because then it gets really expensive for us having to provide a navigator for everyone who needs to access services. Be a lot easier if we could just provide services in a way that worked for people. I actually have a meeting right after this too, so I'm gonna bounce if that's all right. But my email is in the chat, I think twice.
Yes.
And I love questions, so hit me up. I'm happy to connect folks to the programs in their communities. I'm happy to answer questions. If you just want to vent, I'm open to that too. Yeah, appreciate y'all.
Well, I want to say thank you, Maida, on behalf of everybody. We appreciate your time. We know it's valuable. Thank you for last minute coming in and taking care of this for me today and being so knowledgeable in our community. And I will see you at the next meeting.